Well, thank you. I'm Seth Kalishman. I'm going to introduce our speaker today. And I've introduced a lot of speakers. I don't know that I've ever had the opportunity though to introduce one of my real heroes as a speaker. And so it's a great honor to welcome David Holtgrave to do this InCHIP talk today on World AIDS Day. I won't spend a whole lot of time on this introduction because I don't want to take time away from David's talk, but he is a truly remarkable human being in the world of HIV prevention and treatment and care. David received his PhD in quantitative psychology, which he has used quite well from the University of Illinois. He did a postdoc at Harvard. He's held academic appointments at University of Oklahoma and Medical College of Wisconsin. But what David is really known for is the policy trajectory of positions that he's had. He's been a department chair at Hopkins, and he's currently, I still think, holds the position of Dean of the School of Public Health at SUNY Albany. But during the course of his career, he has held a number of positions at the CDC, and in important policy roles. He was the director of the the Division of HIV/AIDS Prevention at the CDC. He was a professor in the School of Public Health at Emory. And as I said, he was department chair at Hopkins and now the dean of the School of Public Health at SUNY Albany. His current position is he's a senior policy analyst in the White House for national drug control policy. So I don't know anybody who has had that kind of career trajectory where he has held, it's almost like two tracks of career trajectories in policy, in federal government, and in academics. And I think working in the White House and being the dean of School of Public Health at SUNY Albany, I sort of like, I can't imagine what could possibly be next. So this is really remarkable to have you here today with us, David. David's going to talk to us on translational research in HIV and substance use prevention and care, reflections on key lessons for conducting rigorous, actionable research. Thank you again for being here, David Holtgrave.
Oh, thank you so much, Dr. Kalishman. I so appreciate this. And it's really an honor to be here as part of this amazing lecture series. And it's been great to be a colleague of yours at Medical College of Wisconsin and all throughout the years, Seth. And the important work that has happened at CHIP and now InCHIP and at University of Connecticut in general on HIV has been truly impactful, both in terms of its consequences and its contributions to addressing health disparities and building health equity. And so much amazing work has gone on there, from the work of Dr. Lisa Eaton to the work of Dr. Kalishman, and also the major contributions that the journal AIDS and Behavior has made to addressing HIV in the US and around the globe. It's an amazing, impactful journal, and Seth has done an incredible job as editor of AIDS and Behavior. So Seth, thank you very much for that extremely kind introduction. It's great to be with you all again today and to be able to share a few thoughts on translational research on World AIDS Day. I wanted to say that my friend and colleague at the Office of National AIDS Policy in the White House, Director Harold Phillips, lent me 3 slides today, and this is the first of one of them. I just wanted to remind us all about on World AIDS Day, as we think about the consequences of the HIV epidemic, what are we recommitting ourselves to? And the World AIDS Day priorities are that we're committing ourselves to ending HIV everywhere, to advancing a holistic and status neutral approach to testing and services, to addressing discrimination and stigma, leading with equity, and engaging all sectors of society and all levels of government. And I think, and this is an important reminder, because always on World AIDS Day, we reflect on the lives that have been lost to the epidemic over the decade, the impact that this has had in terms of health equity over the many years of HIV in the US and around the globe. And because of that level of loss, we really always want to do the most impactful work that we possibly can as quickly as we can. And that's why I wanted to share some thoughts about translational work today. I think when I think about implementation science or translational work, I think about trying to urgently use the best available evidence that we have to inform timely program decision-making and policy-making as close to real-time as possible, and to do it in a way that has the maximum public health impact and the maximum impact on building health equity. So that's sort of the reasoning behind choosing these topics to focus on today. And first, I'll say a little bit about some implementation science frameworks that I've come to really appreciate over the years. Secondly, talk a little bit about some of the applications of these frameworks in HIV prevention and care. And then talk about the intersection a bit between HIV and substance use. And now that I work here at the Office of National Drug Control Policy, where I'm the Assistant Director for Translational Research and lead an office within ONDCP called the Office of Translational Research, I wanted to highlight how some of this work in translational science relates to substance use and how we're trying to use that here at ONDCP. And I should say, too, I'm actually on leave from the University at Albany while I'm here at the White House Office of National Drug Control Policy. So that's sort of the outline for our time together. And I look forward to leaving some time that we can have some discussion at the end as well. So in terms of frameworks, this is one framework that I wrote about after working at CDC for several years, as Seth had said earlier. And the division that I had the privilege of directing at CDC had 5 branches, one that funded program work in the field, another that did applied research, a program evaluation branch, a communication branch, and a capacity building branch. And much of what we were trying to do in that division was sort of move evidence into the field so that programs were as evidence-based as possible, but at the same time, bring questions from the field to the research agenda so that the scientific questions that we were answering were as impactful and as meaningful and contemporary as possible. And so in this 3-box model here, we have this bidirectional arrow at the bottom talking about the dialogue between scientific information and program and policy decision-making. But also, I put this box in the middle on quantitative policy analysis to show that depending on how we package our science, it might lead to greater uptake of that information. If we include cost information, such as a project that I have the good fortune of working with Dr. Eaton on right now, it might be able to let us talk about the economic impact as well as the public health impact of a particular intervention, or to be able to talk about its relative cost effectiveness. And some of these techniques in the middle box may be ways to facilitate this dialogue between science and program and policy decision-making. And when we think about implementation science, I think the frameworks are helpful to keep in mind. So this is one from Lobb and Kolditz in Annual Review of Public Health. And they talk about the goal of implementation science in the health arena is to identify factors, processes, and methods that can successfully embed evidence-based interventions or evidence-informed interventions in policy and practice to achieve population health. And then they give their own definition of what evidence-based means. And that might be something we want to talk about today. What's our broad definition of evidence-based? And importantly, in that same article, they draw on the work of Greenhall and others to show that when we're talking about the uptake of interventions, it's not just here's some science, we publish it, and now somebody's going to pick it up and use it to make a program or policy choice on it. but rather that we need to think about a lot of systems-related information, such as systems antecedents, systems readiness, or programs ready for that particular kind of intervention. Does it have to be adapted in some way before it's used in the field? How can it be implemented in detail? What are the consequences of that adaptation, and so on? So I won't go through all of the many factors that they list here, but just to say that when we think about the uptake of scientific information, it's important to keep in mind that all of these kinds of factors, of course, come into play. And this other hexagon model, which is similar in spirit, but has a slightly different take on some of the details from the National Implementation Research Network, talks about when we're trying to think about adapting an intervention, asking ourselves not only questions about the evidence for the intervention, but are community organizations and communities themselves ready for the intervention? Is there the organizational capacity to deliver it? Do people feel there's a perceived need for it? Does it fit in many ways? And are there resources to be able to deliver it at the scale that's necessary? So again, it's not just a unidirectional arrow here, but really a bidirectional conversation with many factors when we think about uptake of different kinds of scientific based interventions. And the Fogarty International Center from NIH has a definition of implementation science, but I'm always very compelled by the intent, their version of the intent of implementation science, that it's to investigate and address major bottlenecks, for instance, social, behavioral, economic, and management bottlenecks that might impede effective implementation, testing new approaches to improve health programming, as well as to determine a causal relationship between the intervention and its impact in the field. So all of those frameworks, all of those definitions, I wanted to just lead with to talk a little bit about some of the philosophy behind implementation science and translational research. And now I wanted to shift a little bit to, over time, this has almost become an area of professional work in and of itself. So this is from 2012 in Science, and they were talking about emerging professions in science. And they named one a knowledge broker, that someone is kind of facilitating this dialogue between program and research, and that you're sort of brokering that information. And even in more detail, this is from Catherine Fisher, who talks about not only a knowledge broker, which you can see here in sort of the medium blue, who's improving knowledge use and decision-making, but also going to an innovation broker to think about how do you change contexts to enable innovation in the field. And even sort of short, perhaps, of being a knowledge broker, talking about being a knowledge intermediary or translator of helping people make sense of and apply information. And even before that, an information intermediary, where we're just trying to help people get access to information from multiple credible sources. So lots of different sort of roles that are emerging in this space. And just a couple of applications for that I wanted to highlight. One is from Dr. Nazreen Jazani, who at Hopkins, I had the good fortune of being on her dissertation committee. And in her dissertation, what she looked at was for all of the schools of public health in Kenya, she interviewed faculty, administrators, and tried to understand, were faculty doing work that looks like knowledge brokering or knowledge translation, and interacting with decision makers and policymakers, and how was that experience going, and was it rewarded, was it not rewarded? And it was really such an interesting study, I thought, to look at the question of linkage between academia and government decision-making in an empirical way, that actually Nazreen, after she finished her doctoral degree, continued to work with us at Hopkins, and we redid the study with Hopkins faculty from the School of Public Health, looking at at the state, local, state, and federal level, to what degree people were doing work that was like knowledge brokering or translation. And there's a number of papers that we've published that are in the literature on the experience of Hopkins faculty and that translational process. So I think this translational work can be an empirical area of inquiry in and of itself. And the other thing that I think is important to just always keep in mind is that implementation research may be quantitative, it may be qualitative, it may be mixed methods, and increasingly, I think a lot of the work in this area really is mixed methods work, that we're learning a good deal depending on which lens we use to try and inform our understanding of the translational process. And just another quick example of a different kind of outcome in translational work is I wanted to highlight a series of projects we did with AIDS United called Positive Charge. And the purpose of Positive Charge was to try and help organizations improve linkage and retention to care for persons living with HIV across a number of different cities. This was a book that we published that looked at 5 grantees and their partners. I just put the disclaimer here. I have declined all the royalties from anything that has ever in the past or would in the future come from this book. So I had no financial interest in referencing this particular book. And just the example I wanted to pull out of that work, though, was this is a sociogram of HIV care service providers in Louisiana before the Positive Charge work began. And you can see there were some linkages here among the service providers. So clients who were going from one organization to the other, there were some pathways here, but it wasn't a particularly dense network at the outset. So in Positive Charge, the intervention, as you can see in the last sentence on this slide, was to deliver an intervention to strengthen the case management model in Louisiana to help foster the work of health educators and navigators who are located at hospitals, and a post-release case manager model focused on persons who were living with HIV and had experienced incarceration, and also community-based peer health navigator model. So the interventions were organizational. And another way of thinking about that is these, again, are acronyms for service delivery organizations, and trying to look at the whole care cascade from identifications of persons living with HIV not in care, who were linked to care, who had an HIV primary care provider, and who were retained in care and supportive services, and making sure that there were providers at each of the stages of the continuum. And after this intervention was delivered, we redrew the sociogram based on how clients were able to go from one organization to the other. And the main point I wanted to just make here is the network became much more dense from a social network point of view. There were a lot more pathways for clients to move from one organization to the other, lots more opportunities for case management and integration of care. And also, I just wanted to highlight this because I think when we talk about things like translational research or implementation science, some of the outcomes can be very different than what we might traditionally think of in doing HIV work. In this case, density of the organizational sociogram was an outcome that was of considerable interest to us. So it kind of expands the repertoire of different metrics that we might wish to measure and look at. Another study that I believe Seth Kalishman will remember from years ago when we were both at Medical College in Wisconsin was Jeff Kelly and others did a project looking at whether or not you could take evidence-based interventions and deliver them to community-based organizations. And was it better to transfer that information by just providing the documents, the paper about the evidence-based interventions, or should you do that plus have training sessions Or should you do those two things plus having a hotline that people could call and get problem-solving information about the intervention? And this paper in AJPH in 2000 showed, not surprisingly perhaps, that more was better, and especially instead of just providing the documents themselves about an evidence-based intervention, it was especially important to also have some training sessions that people could go through to really talk through how do you take an intervention that might be desirable in your community and really think through how would you provide it, how would you address issues that might come up. And also the hotline that people could call was also useful, but it was those training sessions that were especially impactful. So again, just another kind of study where one could look empirically at this translational process. And there have been some other studies after that by John Germont and others looking at a similar way of studying that translational process. So a couple of words about HIV and COVID, just to say, since COVID was such a major public health challenge, that there were different ways to draw on some of the experiences from HIV and help inform COVID and vice versa as well. So this was just a paper where we looked at were COVID outcomes different with or without diagnosis of HIV infection in New York State. And this was done with a number of colleagues at the New York State Department of Health and University at Albany, where I'm on leave from at the moment. And I think it was really helpful to be able to look at whether or not COVID was having a differential impact on persons living with HIV. And what we found was it seemed to be that was the case. And some of this information wound up being utilized in this interim guidance for COVID-19 and persons living with HIV. And just to skip to the bottom sentence, that based on some recent literature, this included that persons living with HIV tended to be at an increased risk for severe outcomes with COVID-19 and should be included in the category of quote unquote high risk medical conditions when at this moment in time, there was the real issue of vaccine priority. There wasn't enough vaccine to go around at this moment in 2020. And there was a real sense of who should get the available vaccine first. And this was really helping to inform the question of whether or not persons living with HIV should be considered at high risk and be a priority for vaccination. Also, just another example here where we had, where in the literature, you can see how a number of people took lessons from the fight against HIV over the years and tried to inform COVID responses. And had the good fortune of working with Seth Kalishman on one such paper, looking at planning and how planning was done in HIV and how that could inform COVID-related planning as well. And another way I think that HIV has contributed in terms of data analysis to other areas, including COVID and substance use, it is this care cascade. And I'm sure everyone on the call and all of those who have worked in HIV know about the care cascade, from persons who are diagnosed to receive care to being retained in care and having viral suppression. And these continuum were incredibly important because not only did they tell you how things were going nationally and were kind of the centerpiece of metrics for looking at progress in addressing HIV in the US over the years, but you could also break that cascade out by race, by ethnicity, by gender identity, by sexual orientation, by age, and so on. And this is just one such paper that looked at some of those factors and really look at where were the health disparities most marked. And this particular one slide looks at age from a paper in 2013. And you can really see for young people, the cascade was much worse all the way across the board, and that you really want to be able to intervene more aggressively to not only address the cascade and the shape of it for all ages, but really it shows there are some major challenges for young people living with HIV. And Also, one of the other kinds of projects we did was to use that approach to thinking about the HIV care continuum and using it to examine health disparities in COVID. So in 2020, and this was back in June of 2020, we constructed a care cascade to look at COVID in New York State, and we're able to look at race and ethnicity in that care continuum as well. And it really helped look at not only were there differences by race and ethnicity in COVID-related fatalities, but all across the continuum. And in fact, if you wanted to address the COVID-related fatalities in terms of health disparities, you really needed to think about making sure that you were doing work all the way at the left of the continuum as early on as possible to address exposure to virus, early infection diagnosis, and so on. So the continuum can be used in lots of different ways. And the next two slides were, again, from the ONAP director, Harold Phillips, who wanted me to be sure to include, and this is right on point, that there's a recent issue of JAIDS and another of AJPH that are sort of compendia of evidence-based interventions. The one in JAIDS used implementation science to address the ending the HIV epidemic approach in the United States. So really interesting special issue focused on a lot of aspects of implementation science. And then also in AJPH, it was sort of a compendium of information related to intersexual stigma and discrimination to improve HIV-related outcomes. So both excellent resources. And also, Director Phillips highlighted an important issue, which is that CDC has recently funded some models for community to clinic status-neutral HIV prevention and care services for transgender persons. The Indian Health Service has done more work in ending the HIV epidemic to address elimination of HIV and HCV in Native American and tribal nations. And then SAMHSA also recently invested $44 million across 3 Minority AIDS Initiative or MAI supported funding opportunities to look at mental health and substance use services for persons living with HIV or at risk for acquiring HIV. And there's an emphasis on PrEP and on geographic priorities where there was a higher level of HIV transmission. So some more recent important opportunities that are just unfolding sort of as we talk. And then I'll take just the last 15 minutes, and I want to make sure and stop by 1:15 so that we've got a bit of time for your thoughts and suggestions and conversation. To address some of the ways that we're trying to use translational work here at the Office of National Drug Control Policy. So in 2021, within ONDCP, there was a couple of new offices were established, an Office of Public Health and an Office of Translational Research. Beth Conley, who was formerly at Pew, heads the Office of Public Health. I direct the Office of Translational Research. Again, this is within the White House Office of National Drug Control Policy. And for our translational research unit, our OTR for short, our really sort of working mission statement is to try and save lives and build equity through the use of real-time, actionable, rigorous data to shape, inform, and evaluate priority substance use programs and policies. So again, all of this kinds of translational work that we've been talking about in the frameworks and applications in HIV, and using it in the realm of substance use as well. And some of the major areas of emphasis, and then I'll show a slide on most of these quickly, is we're asked to fact check everything across ONDCP. So for instance, the National Drug Control Strategy that was out earlier this year in 2022, one of our duties was to literally look through every sentence to see if all of the assertions, all of the uses of statistics were right and could be taken back all the way to primary sources. So really a very high bar in terms of the use of science in those documents and making sure that they're credible and can be well sourced. Secondly, we do work looking at trends in fatal drug poisonings in the U.S. to see if there's emerging patterns. A major emphasis for us is looking at non-fatal drug overdoses. One of the most important predictors of a fatal drug poisoning is previous non-fatal drug poisonings. And so that's an important area that we're trying to address. Also, naloxone administration information. How much unmet need is there in the U.S. for naloxone administration? How many people need naloxone that are currently not getting it? And what are the best ways to think about implementing enhanced naloxone administration in the country? Also, the cascade of care that we talked about at HIV and COVID, adapting that into the substance use arena. Information on various kinds of interventions, especially in the harm reduction and recovery services. Emerging threats. One of my other titles here is the U.S. Emerging Threats Coordinator, and part of what that involves is always looking for new emerging types of substances that may be of additional concern as we go forward, and then also modeling the consequences of meeting the goals of the National Drug Control Strategy that came out earlier this year. And on several of these, I've got just one slide or so that I'll go through quickly in our last few minutes before we open it for discussion. In terms of thinking about analyzing fatal drug poisonings, in the U.S. right now, there's a life lost to substance use about every 5 minutes. It was as high as 110,000 in a rolling 12-month total. So when CDC numbers come out on fatal drug poisonings, they're in rolling 12-month totals. And it peaked at 110. Now it's been declining for the last few months, and this rate of increase that you see here has also been slowing in terms of the rate of increase and almost a flattening over time. So we're really making sure that we're spending some effort trying to understand what's the pattern look like? Is there any slowing? Is there any flattening in fatal drug poisonings? And but still, even at this level of over 100,000, we have to make sure that we're redoubling our efforts to try and do everything we possibly can. The goal on the National Drug Control Strategy is that by 2025, this number would be down to 81,000, no more than 81,000 fatal drug poisonings per year. So that's really the goal, to try and make sure that not only does the rate of increase slow and flatten, but that it eventually comes down to 81,000 by 2025. And I'll come back to that again later. With regard to non-fatal overdoses, this is just a paper that the ONDCP director, Dr. Gupta, and I had recently in JAMA, talking about the vision for addressing non-fatal overdose data in the U.S. We have a kind of now a mosaic of partial information around non-fatal overdose. We have some information about emergency departments. We have some information from poison control centers. We have some from toxicological kinds of reports and various sources. And what we're really talking about in this paper is what would a more comprehensive system look like, and perhaps even could substance use poisonings be included as a notifiable condition. This is called for in the National Drug Control Strategy, that it would be desirable if we could move in that direction. And we go into a bit more detail there. So just to say, non-fatal drug overdoses is an important area for us, in thinking about how can we bring the most information together as quickly as we can. And one of the reasons that's really important, it ties to the topic of naloxone, because if there's 108,000 or so fatal drug overdoses in the U.S. and multiple non-fatal overdoses for each of those fatal overdoses, we want to make sure that we're using naloxone to reverse the effects of a drug poisoning as quickly as possible. And how to get information about the number of doses that are needed, as well as how many doses of naloxone are actually administered. So one partnership that we have that's ongoing and really vibrant is with the National Highway Traffic Safety Administration, and they have an EMS dashboard or data set that provides a lot of information about traffic safety, auto accidents, and so on. But because substance use may also be involved in emergency medical service provision, one can sort of pull on that thread and use that data set to get a bit more information. So one of the things that can be pulled out of that is the extent to which naloxone is administered by emergency responders. That's very helpful. And we're also working with them on using that kind of data set to estimate the number of non-fatal overdoses that are attended to by emergency responders. So the issue of fatal overdose, non-fatal overdose, and naloxone administration are all very much tied together. And the issue of how to get the most comprehensive data as close to real time as you possibly can is really important. And I kind of keep saying the phrase real time as we go through, because I think when we're talking about translational research to inform program and policy, the timing of the information matters. And the closer it is to real time, the more you can think about whether one would want to set policy based on that that information. And the older the data gets, perhaps the less relevant it may become in terms of informing program and policy. The care cascade, I wanted to just highlight for a minute. We have such an experience level with the cascade in HIV and somewhat in COVID. This is the from the National Drug Control Strategy, drawing what the bars might be if you applied the notion of doing a cascade in the substance use arena. And one of the things that you sort of immediately see, and this National Drug Control Strategy was out in the spring of 22, is that there are a lot of data gaps here. And that if you wanted to fill that in, you would want to be able to try and improve the timeliness of some information, such as treatment information, so that you could be as real time as possible. And just one attempt to do that, we worked with Admiral Levine and Dr. Gupta and Dr. Cepeda at Hopkins to talk in the New England Journal about treatment of opioid use disorder. And could there be a movement to even more universal availability of treatment for management of opioid use disorder? And how could we use some of the medically assisted or MOUD approaches? And in that, one of the things we tried to do was, here it's presented as a pyramid as opposed to the usual cascade form, but we tried to go from the population of 12 and older to the number of persons who had opioid use disorder, what numbers were reported on the National Survey of Drug Use and Health, or NSDA for short. And in NSDA, to what extent people reported receiving treatment at a specialty facility and who had received MOUD or the medically assisted forms of therapy. And there's different ways to think about this pyramid, and one could use some additional data sources that are focused just on treatment, such as surveys of treatment facilities as opposed to surveys of persons, to inform this. The main thing, though, is you really find that somewhere between 5 and 10% of persons with opioid use disorder are probably receiving medically assisted therapies or MOUD. So that really suggests that we've got much more work that can be done to provide these kinds of services. And that's really highlighted in the National Drug Control Strategy. So I just use this to say this care cascade form, whether it looks like the usual cascade or a pyramid or whatever, can be really helpful in trying to assess how much met and how much unmet needs there are for different kinds of services in the country. Also, thinking about the evidence for different kinds of interventions, this is just from CDC, their Syringe Services program fact sheet, where they try and summarize what do we know about the interventions on effectiveness and to some extent the cost effectiveness of these programs. How do they lend themselves to improvements in HIV and HCV? And of course, syringe services programs are very important in thinking about harm reduction in the substance use arena. So just one example of thinking about these kinds of compendium, I should say, of evidence-based interventions. And I'll spend just maybe 3 quick slides on the issue of emerging threats. As I said before, emerging threats is an area in substance use that we're charged with to look at, are there either new drugs or new combinations of drugs or new adulterants, or new populations or new patterns of polysubstance use that would lend themselves to saying, here's something that's new on the horizon, and maybe we need to be paying more attention to it. And there's even some criteria in the Support Act, which is an important piece of legislation around substance use from 2018, that talks about what it would take for something to be considered an emerging threat. And ultimately, the director of ONDCP can make that designation. One of the things we've been looking at a lot lately is xylazine. Xylazine was developed first as an antihypertensive, then approved as a sedative and analgesic in veterinary medicine. And over time, what we have seen some more of is using it especially as an adulterant to fentanyl, because it expands the experience of fentanyl to last a longer time. I should say too, in just very recently, the FDA issued a xylazine warning to healthcare providers in the U.S. That this was a substance that was being seen a bit more, and that healthcare providers may wish to be on the alert for this. If we look at the Suitors database, this is a CDC database of about 40% of all the fatal overdoses in the country. You can see that the number of deaths that involved xylazine has been going up fairly rapidly. I won't get into all of the statistics, but the growth of xylazine as it relates to fatalities is going up. And this is from just 2019 through 2021. The number of states reporting xylazine-involved overdose deaths is growing rapidly as well, too. So it seems to be an important area. And I just wanted to highlight that because it really can inform program management and policy by looking at data and trying to translate it over time. So in October of 21, the DEA requested a scheduling review of xylazine, and then the FDA warning to healthcare providers just came out in November of 22. And a number of states and localities have issued warnings. This is one in the graphic on the right side from Philadelphia, where they're trying to provide information about xylazine, what do people need to know, and also starting to, it's started to have a name of tranq for shorthand, for short for tranquilizer, because it is a veterinary tranquilizer, but people are referring to it as tranq by shorthand. So this is just Philadelphia's approach to trying to provide further information about this. And I just wanted to mention this area of emerging threats because I think it's an interesting one to think about, especially from a mixed methods point of view. How do we identify things that may be impacting public health, individuals' health, and health disparities over time, so that we identify them as soon as we possibly can? And then the last, second last slide that I have is just to say, in terms of modeling the impact of meeting the goals of the National Drug Control Strategy, what we see here in blue is just sort of observed fatal drug overdoses in the U.S. over time. In red are the, let me do green first, please. If we do green, those are the yearly goals from the National Drug Control Strategy, trying to get to 81,000, no more than 81,000 fatal drug poisonings per year by 2025. But then we projected if one did nothing. And so in red, we're trying to develop a counterfactual here. If one did nothing, if you saw the percentage rate of growth continue over time, it may be that you would have had as many as 164,000 fatal drug poisonings per year. Of course, reasonable people might disagree about exactly where that red counterfactual line should be, how you would estimate it. But the main point that we were trying to see here is if you look at the yellow shaded area between the counterfactual and the green targets, it's really a substantial number of lives that could be saved if we could could reach, I should say, the goals of the National Drug Control Strategy. In fact, if you add up all the area between the curves, it's a little over 160,000 total fatal drug overdoses that could be saved. And that 160,000 total is actually coincidental to that last number on the counterfactual of 164,000. But the area that's shaded is about 160,000 lives saved by meeting the goals of the National Drug Control Strategy. So whether it's exactly that number or somewhat more or less, really a substantial number of lives that could be saved if we can implement the strategic actions that are included in the strategy. And I know that I've gone just a little bit over time, but I'll show one last slide is to say, again, so honored to have been included in this lecture series. Great to be able to see old friends and meet new friends here today. And I hope that this discussion of some of the frameworks of implementation science was useful, talking about how we can apply these in HIV prevention and care, and then also giving some illustrations of how in the Office of National Drug Control Policy, we're trying to think about translational research and what some of the activities are looking like. And just in the last word, I know on World AIDS Day, we all reflect over the last decades of how many people we've lost either individually or in families or communities or collectively to HIV, and also people who have been very strong allies and have worked very hard in this arena. And I just wanted to, I couldn't give this talk on World AIDS Day without saying the names of Dr. Dawn Smith and Deputy Director Janet Cleveland from CDC. Many of you know Dawn and Janet. They were really pioneers in looking at PrEP and in HIV prevention community planning and the Minority AIDS Initiative over time. And they contributed so much to addressing HIV in the United States. They both passed from us in the last few weeks, and we miss them very, very much. And I just couldn't give this talk without saying their name. I know that they rest in power. And thank you for letting me take a moment to honor their memory. And with that, I will stop. Thank you again for your time and look forward to any comments, questions, suggestions. And I believe at this point, I turn it over to Dr. Lisa Eaton to moderate our session. So Lisa, over to you.
So thank you so much. That was incredible. It's always wonderful to sit through one of your talks, and I'm just utterly in awe of the breadth of your work and the capacity for your work to have a huge impact on policy-related changes. I mean, it's just a really amazing talk, and it's like it's hard for me to just watch the talk and like not get overwhelmed just by the slides and thinking about like the areas that you cover. I can't imagine what your life is like on a day-to-day basis, but I can say with confidence that it's just extremely impressive. And I'm just super grateful that you spent your time with us today. So I know I have some questions, but I'm going to open it up first to those who are with us virtually, and I will also be monitoring the chat. If someone has a question, just go ahead and raise your hand, and I'll call on you. and why people are getting, oh, sorry, go ahead, Daryl. Yes, I see your hand up.
Oh, yeah, David, it's very interesting. Thank you for your talk and update on drug overdoses and so forth, and fatal and non-fatal. I'm chairing a dissertation, and it's an international. I have an international PhD student, and as far as emerging threats, tramadol is the subject of the dissertation, and he's looking at tramadol on Cameroon, Nigerian border. And interestingly enough, maybe unbeknownst to him, which is an email right now on the results, but we have survey data. Also, there's a big Netherlands network that's looking at tramadol. It was kind of new to me as a drug of abuse. I think I'm going to find myself on soft money soon, maybe next year. Is there any interest in ONDCP looking at tramadol? Because I could give you context.
Yeah, no, absolutely. We're very interested in looking at emerging threats broadly, and I think tramadol included. One way I sort of am thinking about this emerging threats area is using an analogy in COVID. In COVID they talked about variants that were being monitored, variants of interest, variants of concern, and variants of high consequence. And if we sort of take that four-part analogy to substance use, it's almost then like, what are substances that we maybe hear anecdotes of early on that may be new concerns? Which are ones that are concerning enough we want to do a deep dive to try and collect more data? Which ones sort of meet some criteria, like there a certain amount of increase in numbers of deaths, a certain amount of geographic spread? And then beyond that, which ones are sort of a really high consequence, like fentanyl being sort of the prototypic example. And so I think at the beginning of that kind of four-part analogy, we want to cast as wide of a net as we can and have the radar screen as broad as we can to learn about different kinds of substances, different kinds of patterns of use. So, Daryl, I would be happy to stay in touch and make sure that we get a chance to talk by email or so on. I'd like to learn more about the dissertation and what you're learning. That would be great.
Well, I appreciate that, because the Dutch are approaching it from like an ecological view on rainforest and drug trafficking patterns where, trees are burned and, cut through to traffic. And we're looking at it as human trafficking and juvenile use, preponderance of juveniles using it, staying out of school. And it has all sorts, it's a cascade of trouble.
Yeah, no, thank you, Darren. I look forward to learning more.
Thank you.
Shay, would you like to go ahead?
Yes, hi, thank you so much. So I know implementation science and translational research are really great tools to start addressing health equity issues. I'm thinking specifically about HIV prevention and care. Like, what are the strategic actions that are being taken at like the federal level to address the gaps that are happening in HIV prevention and care, especially in states where Medicaid expansions haven't been adopted? Are there ways, because there are a lot of people who are at high risk, who are kind of falling through the gaps, and I think it's kind of a great place where translational research and implementation science could come in and kind of address some of those structural barriers.
Yeah, thank you, Shay. No, it's a great question. My colleague Harold Phillips from ONAP would be even better at addressing that. Would be a great speaker in the seminar series. I guess what I would say at the most general level is today the president of France was here for a state visit and got to hear President Biden and President Macron commit the two nations to eliminating HIV by 2030 and to make sure that we're staying on that goal. And so I think, one kind of action is recommitment to making sure that we're staying on those goals. I think another is the kinds of capacity building and translational work that I summarized on a couple of slides from Harold, where we're seeing organizations like SAMHSA and CDC and Indian Health Service provide grants to be able to do that work. And then I think another place where we see it is over time, HIV prevention community planning and the Ryan White care planning councils have kind of merged in many areas. But I think that sort of community-based planning is really an important kind of federally required and locally implemented program, because it's one thing to have the compendium of what might be evidence-based or evidence-informed interventions. It's another to think through all of those different dimensions of implementation science of what's right for a particular community, for faith-based communities in Baltimore, or community-based organizations in Los Angeles, or what from that menu do you want to take? And so I think supporting those planning efforts over time is really important to be able to continue as well. And then I think the other thing that I would just highlight is early in the administration, there was a executive order signed to look at equitable data and improving health equity in programs. And we're seeing a lot of work in that area. I serve on a couple of working groups here, one on SOGI data, another more broadly on health equity and the use of data. And I think that matters because the direction that those efforts are heading is how do we take best practices about how we assess health disparities and measure health equity, and how do we make sure that that's available in all different kinds of data sets. So for instance, one of the things recently I was very interested, how could we take like questions from the CDC and HBS on SOGI data and apply them in areas in substance use that may not has had a long as a history in assessing SOGI data. So the kinds of data we collect, I think, is also another important initiative too. So those are just a few things of many that I would highlight. Thanks.
Thank you for that. And I'm just looking to see if others, while I'm kind of looking around, I'm going to go ahead with the question too for me. So I'm just thinking through the data that you presented on the very high level of overdose deaths that we're observing and the very rapid increase as well. And I'm just wondering if you can talk through what is at the root of driving that very high rate and the shift, the increase. What do you see as like the biggest factors driving that change?
Yeah, no, it's a great question, Letha. And I would I'm happy to give my answer, but also would love to hear if there are thoughts in the group about other hypotheses as well too. I think when we look at it even more recently, the rate of increase has tended to slow some. And just in the last few months, if you look at 12-month rolling total and then the next 12-month rolling total and the next, you've started to see a little bit of a flattening. Also, instead of looking at 12-month rolling totals, if you take from CDC's Wonder data set, just one single month at a time, you've started to see a little bit of a flattening as well too. So I think there may be a number of contributing factors there. I think even before COVID, we started to see that increase go up. And I think a lot of that was related to fentanyl related introduction and use. The drug supply was just getting more and more lethal over time with the introduction of fentanyl, and so I think that's a huge issue. Also, I think with fentanyl, we're now seeing additional polydrug use, such as a number of the xylazine cases that I talked about are co-occurring between xylazine and fentanyl, and one of the concerning things there, I think, is because xylazine is not an opioid, are in some ways the best resuscitation tool you have with regard to opioids is naloxone. If someone is using xylazine and fentanyl at the same time, whether it's knowing or unknowing, it may be the case that either naloxone isn't effective at all or is diminished in its effectiveness. You'd still want to use it to try and address the overdose related to the opioid piece, the fentanyl piece. But you need another way to address with assisted breathing, managing airways, and so on to address what's happening with the sedative with xylazine at the same time. So attempts at resuscitation have gotten much more complicated, I think, as we see these different patterns of use. And then, there may have been during the time of COVID, some effect of the pandemic occurring there as well, too. And so now I think, we're always looking at the data to try and sort that out. So those would be some of my leading hypotheses, but at least if you have thoughts or others in the group have thoughts, would love to hear them as well, too.
No, I'm not familiar with xylazine at all, but when you had started talking about that, I was wondering if that was a contributing factor in that increase, which is very, very concerning. Especially listening to you talk about kind of like the I guess permutation of the messaging about xylazine. I don't know I can imagine the challenges of getting messages about new medications or the use of new medications to individuals who are in need of receiving those messages. I can imagine that's quite challenging. And unfortunately also leading to the potential for a higher rate of overdose outcomes. Oh yeah, sorry, David, go ahead.
No, you raised such a good point, Lisa. I was just going to expand just for 1 second. Yeah. I think the communication efforts and thinking about all of the different audiences, like the FDA warning about xylazine to healthcare workers is important, but healthcare systems overall, persons experiencing substance use, service provision organizations like SSPs, family members, communities overall. There's a lot of different really key important audiences, persons in recovery, organizations serving persons in recovery. And there needs to be custom tailored messages that are really done in many of the ways that we've been doing HIV related work for so long. Yeah. Starting by listening, starting by doing that kind of community-based participatory work approach to that as well. So I just was resonating with your point, Lisa.
Absolutely, 100%. Okay, I know that you are on a very tight schedule, so we won't keep you any longer. And I just want to say that I think on behalf of all of us, we're just very grateful for your time. This has been an excellent presentation, and I hope to talk with you soon.
Absolutely.
I have emailed you.
Yes, no, that's right. And so everybody knows Dr. Eaton and I are finishing one more paper on cost-effectiveness in HIV. So look forward to it. And thank you all again for having me. I really appreciated the discussion today. Thank you so much.
Thank you so much.